Assalamualaikum everyone. I am going to present today's topic, history and clinical examination in the urological field. Learning objectives of today's presentation is the format of history taking, common urological symptoms, and the clinical examination in the urology. In the work of any patient, the history of paramount of the importance. History taking values about the 70% in reaching the correct diagnosis and also direct the use of other tools. Can anyone tell me what are the usage of the other tools basis on the history? What does it mean that the usage of the other tools? Like which investigation, how we will relate it to the history?
Depending on what we found out in the history, we will make a differential, and then based on that, we can decide what kind of blood tests or radiological tests we want to carry out.
Exactly. Like the history, about the 70% of our diagnosis is based on the history, and then examination, and they will direct the investigation according to the basis of our history and the examination. Goals of the history taking. What should be the goals of the history taking from the patient? What was in our mind that when we are taking from the history in any patient? Building a good relationship with the patient, formulating the workup plan, reaching a diagnosis, and planning for the management. Our whole purpose for the history and management is that the history and examination is that we can manage the patient accordingly regarding basis on the history and the examination that what patient is going through the problem. The format of history taking includes introduction, personal history, chief complaint or the presenting illness, history of present illness, past history, which includes the medical, surgical history, trauma history, transfusion history, travel history, and the systemic review. Each point has its own importance regarding in the history. Introduction and personal history. It starts with introducing yourself, then asking the name. First name and the second name is very important because we are used to familiar with the patient coming with the same name. Then the age, gender, occupation, residency, marital status, comorbids, addictions, educations, menstrual and reproductive history in the females patient.
Anybody can volunteer yourself. How will you introduce yourself to the patient? Anybody? Asad. How will you introduce yourself to the patient? When are you going to take the history? How?
Ma'am, first of all, we will greet the patient, and then we will.
I'm your patient.
Like, yes. If she's your patient or I'm your patient, you are coming in the clinic. How will you introduce yourself to me?
First of all, like I will say, Assalamu alaikum. My name is Dr. Saeed Asad Masood, and I'm a urology resident at SIT. And, okay. Like मैं ये कहूँगा कि मेरा नाम सैयद असद मसूद है और मैं यहाँ पर यूरोलॉजी का ट्रेनी हूँ, यहाँ पर डॉक्टर एज ए डॉक्टर काम कर रहा हूँ SIT में। और आपका नाम क्या है? फिर पेशेंट से उसका नाम पूछेंगे, तो उसके बाद फिर लाइक उनसे उनका एज वगैरह, उनका मैरिटल स्टेटस, जैसे ये।
अच्छा, ठीक है। नजीब, कैन इट बी मोर बेटर?
जी, मेरा नाम डॉक्टर नजीब है। मैं उस टीम का हिस्सा हूँ जो आपका इलाज करेंगे। मैं आपसे आपकी बीमारी के बारे में कुछ सवाल पूछना चाहूँगा ताकि हम आपकी तशखीस कर सकें।
When we are taking the history, the major hazards which come counter is that the language barrier. So first you should ask the patient that he or she is understanding your language or not. And then you can start from introducing yourself. Presenting complaint. That the chief.
And one more thing, when you are entering the clinic, you have the OPD slip or the OPD paper mention the name of the patient. It's better you see the name of the patient and then talk to the patient like Mr. XYZ, Mr. ABC, my name is this. How are you? इस तरह से greet करेंगे तो it looks more comfortable to the patient. ठीक है?
The presenting complaints. It is the main chief complaint through which the patient comes to us in the OPD or in the emergency. And they ask the patient from the presenting complaint that which complaint which he or she come to this, and then we'll go for the history of the presenting complaint. History of the presenting complaint, that the main reason to visit the urologist is the chief complaint. Positive findings should be mentioned first and then includes the negative. Symptoms arranged in the chronological sequence. What does it mean? That how you will arrange the symptoms in the chronicle sequence. Suppose a patient come with the pain, hematuria, and the fever. How will you arrange this in a sequence?
Like we will ask the patient which symptoms, the onset of symptoms, which symptoms came first, the duration, how long it persists, and the same way the other symptoms, like if he had the flank pain and then subsequently he developed hematuria, then we will ask that how long the complaint of hematuria he's having. So that's how the
And then we start, and then we will ask from the onset, duration, timing, severity, aggravating, and the relieving factors. History of this previous similar episode, and history of the investigation and the treatment for the current illness. Common urological symptoms that we've encountered in our daily practice is the pain, hematuria, lower urinary tract symptoms, swellings of the lumps, and the associated symptoms like the patient coming with the symptoms of the renal failure, or other patient with coming with the genital symptoms like the erectile dysfunction and then fertility and the impotency. The pain, the most common symptom we usually encounter, that can be start from the renal, ureteric, bladder, prostatic, Nile, urethral, and the testicular.
Okay, Farzeen, what are the common questions of pain you ask usually to the patient?
We'll start with कि आपको दर्द कब से है, आपको दर्द कहाँ पर है, कब से है, और आपका दर्द जो है वो ठीक कैसे होता है, और आपका दर्द जो है वो आप ऐसे क्या करते हैं कि आपका दर्द और ज़रा बढ़ जाता है, दर्द के साथ आपको बुखार, उल्टी या इस तरह की कोई और चीज़ या कुछ और तो नहीं होता, और जो है वो we'll ask related symptoms.
Exactly. The pain, we will start from the side, onset, character, severity, radiation, duration, associated symptoms, exacerbating, and the relieving factors. What are the different character of the pain? Can anyone tell me the? It is a basic thing we have learned in our third year and fourth year, the characters of the pain.
It may be dull, character colicky, and sharp,
Thrombing, stable.
thrombing.
And can anyone tell me that what this picture is showing?
Score.
The pain score. When we are taking the history of the patient from the pain, then we will ask him that if you are scored your pain in from the 0 to the 10 points, then which score you will give him. If the patient come in the severe pain, he will give to the 8, 9, or the 10. And if it is a mild and do not bothering his daily activity, then it will be the 1 and 2. Now we come to the renal pain. Renal pain arises costovertebral angle just lateral to the sacrospinous muscle and just below to the 12th rib. It is a dull and the constant, spread along the subcostal area towards the umbilicus and the lower abdominal quadrant. The cause of the renal pain is the sudden distension of the renal capsule due to the anhydronephrosis or the obstruction. The urethral pain. The urethral pain is typically acute and secondary to the obstruction. The pain radiates from the costovertebral angle down to the lower anterior abdomen. In the male, it radiates to the bladder, scrotum, and the testicle. In the female, it radiates to the vulva. What is the reason for the radiation of the urethral pain to these organs?
And due to dermatome involvement, same
innervation.
dermatome involvement, that's why it's left.
The differential diagnosis of the mid-ureter pain, on the right side, it discriminates appendicitis, and on the left side, it resembles like the diverticulitis. So we have to differentiate that the patient is suffering from the mid-ureter pain. On the left side, are it having the diverticulitis or the appendicitis on the basis of the history and the examination. And then we will offer further investigation accordingly. Vesical pain or the suprapubic pain, it is due to the overdistension of the bladder in the acute urinary retention, infection, or the terminal dysuria in the severe cystitis. Chronic urinary retention may cause little or the suprapubic discomfort. Constant suprapubic discomforts is really the cause of the urological origin. And the prostatic pain is direct pain from the prostate is not common. Acute inflammation with the edema can cause the pain due to the distension of the capsule. The prostatic pain is poorly localized to the perineal rectal area or the lumbosacral becket. This is a referred pain. Inflammation of the prostate usually causes the symptoms of the frequency, dysuria, and the urgency. Testicular pain. There are the different causes of the testicular pain. It could be due to the trauma, infection, torsion. Uninfected hydrocele or the spermatocele and the tumors of the testes do not commonly cause the pain, but the trauma to the testes may cause the pain and having the patient with the testicular tumor due to the hematoma or the rupture of the tumor. Referred pain from the upper ureter or the indirect inguinal hernia. Penile pain is the referred or the secondary to the cystitis or the stone. In the flaccid penis, it is usually due to the bladder or the urethral inflammation. Another common problem is a priapism, that is the persistent penile painful erection, which causes the penile pain. And the urethral pain is usually caused by the obstructed stone or the infection. Hematuria, the second most common symptoms which we encounter in our daily practice.
Anybody? Common questions for hematuria. Patient comes in the clinic, Dr. साहब पेशाब में खून आ रहा है. Okay, so.
Apart from the ones that Dr. Misal mentioned, we can ask about if there is history of trauma, if there is history of any recent travel, if there was any recent treatment such as ESWL or any endourological procedures that he received. Excessive exercises and heavy lifting is also associated with hematuria. Drug history, that's very important. We should ask if he's taking any blood thinners. And apart from that, if he had any stone disease or this can be associated with hematuria.
One more important thing, whether it is painful or painless.
Character of the pain, character of
Painful or painless, first of all, we ask hematuria है, painful है, painless है, ये जरूर पूछना है आपने.
And also the occupation of the patient and any history of the addiction, especially to the smoking.
Other important thing for hematuria to ask from patient the time duration while hematuria. If it occurs before the start of maturation, then the origin of hematuria is from the urethritis. If it mixed with the urine, it most likely with origin from the prostate. If there is a terminal hematuria, it likely from the bladder neck or bladder.
Okay, the hematuria is a red flag sign that cannot be ignored. There are the different causes of the hematuria, that mostly the calculi, infection, and the malignancy in the kidney, ureter, the bladder. In the adult, painless hematuria must be regarded as a symptom of the urological malignancy. The origin of the hematuria could be the urinary tract symptom pathology or the systemic causes. As the Dr. Halimullah mentioned, the initial anterior urethral lesion causes the urethritis, stricture, and the meatal stenosis. Terminal is the posterior urethra, bladder neck, or the trigone, and the total at the base of at the bladder level or the above. It could be the stone, tumor, and the tuberculosis and nephritis. Here are the different causes of the hematuria, which is the pre-renal, renal, and the post-renal. Pre-renal includes the anticoagulant, hypertension, or the diet urine, which is considered the false hematuria. Renal includes the cancer, polycystic kidney disease, stone, infection, trauma, and glomerulonephritis. And the post-renal includes the traumatic catheter insertion, endometrial CA, STDs, or the prostate cancer. Lower urinary tract symptoms, the third most common symptoms in our clinics.
Vikram.
जी मैडम.
Loads.
Madam, loads are lower urinary tract symptoms which can be obstructive or which can be irritative. And the irritative symptoms which you can find are frequency, urgency, nocturia. And the obstructive symptoms are whether the patient is having hesitancy, poor stream, and incomplete voiding, straining.
Yeah, exactly. The lower urinary tract symptoms is divided into the irritative and the storage and the voiding symptoms, which includes the frequency, urgency, urgent continency, and the nocturia. And the obstructive symptoms includes the hesitancy, poor stream, intermittency, straining, sense of incomplete bladder emptying, or the post-void dribbling. So if the patient come with the lower urinary tract symptoms, either irritative or the obstructive, what will the differential diagnosis in your mind that what can cause the lower urinary tract symptoms in the patient? Anyone?
It's depend on age. First, we have, yes, so I have to see the age of the patient. Is it if he or she is if he is more than 40 or 45, we have to suspecting the enlarged prostate, and if he is a young age, and we have to go first for the infection or something else with the urethral structure.
So here's the causes of the lower urinary tract symptoms, which include the benign prostatic hypertrophy, detrusor overactivity, detrusor underactivity, neurogenic bladder dysfunction, urinary tract infection, foreign body in the bladder, prostatitis, urethral stricture, bladder tumor, other distal ureteric stones. And there are many other also causes the lower urinary tract symptoms in the patient, whether presenting in the young age or in the old age. And it is important we should take the patient with the associated history with coming with the lower urinary tract symptom, as the patient is a diabetic or the not. Urological intervention has been done previously or the not, CNS problems and the symptoms, previous history of the urinary retention, febrile urethria, constipation, backache and the vertebral deformities, and the trauma history. Because these all can cause to the problem to the lower urinary tract symptoms, to the lower urinary tract, and the patient will present with the lower urinary tract symptoms. The other one is the incontinency. The incontinence is divided into the true incontinency, stress incontinency, and urgent incontinency, and the mixed incontinency. True incontinency is the continuous involuntary loss of the urine at the all time in all position. The common causes of this is the urogenital fistula, which includes the VVF, uterovaginal, and the vesicovaginal. Extrophy of epispadias, neurogenic bladder, or the ectopic ureter.
We talked about urogenital fistula. पेशेंट आपको क्या हिस्ट्री देगा, क्या हिस्ट्री लेंगे आप पेशेंट से?
Mostly these are female patients, and we have to ask about any obstetric procedure previous. Second, we have to take history of tuberculosis in the family.
Vikram.
Madam, we will ask whether the patient is having complete incontinence or not. ऐसी क्या वो पेशाब जब कर रही है तो क्या पेशाब continuous बह रहा है या फिर वो खुद पेशाब भी कर रही है और continuous बह भी रहा है?
What does it indicate?
It indicates that the only one ureter is involved, and the other ureter is patent in the urinary bladder. That's why she's having incontinence as well as continence.
It means whenever a patient comes after obstructed delivery, after any obstructed labor or any gynecological procedure comes in the clinic with a history of urinary incontinence, we should take a detailed history actually. As Vikram mentioned well, we should ask whether she has she does void with the stream or not, or she has only incontinence and she's wet all the time. So this is an important question in order to diagnose or differentiate between different types of urogenital fistula.
The second is the stress urinary incontinency, that is a sudden loss of the urine with a physical strain, for example, coughing, sneezing, or the laughing. In this, the intra-abdominal pressure exceeds the urethral resistance. It is a common in the multiparous women at the mean having the radical prostatectomy in the past. Urgent incontinency is the sudden strong desire to the void with the involuntary leakage of the urine. It could be in the acute cystitis, neurogenic bladder, or the bladder outlet obstruction. Overflow incontinency is the loss of urine due to the chronic retention or the secondary to the flaccid bladder. This is the pragmatic review, the stress, urge, and mixed incontinency. In the stress incontinency, there is a too little tone that patient, when the pressure is increased, the patient start leaking. And the urge incontinency is the patient detrusor is overactive. Then when patient start to the void, it start leaking before the voiding. And the mixed is the too much activity in the too little tone. And the overflow is that the bladder just can't hold anymore the urine and patient start leaking periurethral. Urethral discharge is one of the most urological complaint in the main. The causes is the infection, which include the chlamydia trachomatis and the Neisseria gonorrhea. If the patient come with the complaint of urethral discharge, we should ask from the history of the sexually transmitted disease or any sexual contact history. Nemachuria is the rare sign which is include the passage of the gas in the urine. It is strongly suggests the fistula between the urinary tract and the bowel. The most commonly fistula found in the bladder and the urethra. Carcinoma of the sigmoid colon, diverticulitis with the abscess or the trauma can result in the fistula between the bowel and the urinary tract, and which result in the nemachuria. Now, the second is the swellings. The patient will come with a history of the lumps that could be in the abdomen, groin, or the scrotum. The abdominal lumps due to the hydronephrosis of the kidney, pyonephrosis, tumor, polycystic kidney disease, perinephric collection or the intra-abdominal collection, full bladder or the renal graft. Inguinal lumps could be the hernia, enlarged inguinal lymph nodes, undescended testes, lipoma of the cord, femoral aneurysm or the psoas sepsis. And the scrotal lumps includes the inguinal hernia, hydrocele, epididymal cyst, orchitis, testicular tumor, varicocele, carcinoma of the scrotal skin, and the spermatocele. And there is many other different. These are the reason for the scrotal lumps. Now come to the examination. Examination will start from the general physical examination, and the general principle will be the adequate relaxation and the patient confirm, good light and the warm room, explain the procedure, take the permission, proper exposure, stand on the right side of the patient, and the painful area should be examined in the last. What should be the proper exposure for the abdominal examination? From where to up to when, how we will expose the patient? Yes, Dr. Bilal.
First of all, there are the certain prerequisites for clinical examination. We have to introduce the patient, and we have to take the consent from the patient, and we have to proper expose, and we have to after exposure there should be the proper illumination of the light. There should not be such darkness, so we will be unable to examine. For exposure, we have to expose from the nipple up to the mid thigh. That is one of the best exposure for abdominal examination.
Exactly. So that we can examine the inspect or palpate any abnormality found in these areas. On the inspection, the abdomen is divided into the 9 quadrants, which includes the right hypochondrium, left hypochondrium, epigastric region, umbilical region, hypogastric region, right lumbar, right iliac, and the left iliac. It is divided on the base depending on the organism which is involved, the pathology. In the inspection, we look for the abdominal shape, skin abnormalities, umbilicus, dilated veins, hair distribution, and the hernial orifices. Can anyone explain the inspection finding on these pictures? Nadia? Okay, the patient is showing the plank incision, and the second picture is showing the incisional hernia. And what about this?
Okay, this is rooftop incision.
Chevron
double
incision.
cocker.
Now we start the palpation. For the kidney palpation, the patient should be in the supine position. The kidney is lifted from behind with the one hand on the costovertebral angle. The other hand is placed anteriorly just below the costal margin. Palpate deeply while the patient is taking the deep breath. The renal mass, which will encounter during the palpation, that lies in the loin region, usually the bean shape, moves with the respiration, and the bloatment is present and the dull on the percussion. And it is due to the hydronephrosis, polycystic kidney disease, pyonephrosis, and the renal tumor. Can anyone tell on the left side how we will differentiate that it is the enlarged spleen or the enlarged kidney? on the palpation in the examination.
While examining the spleen, we go from the we go in the diagonal way from the right iliac fossa towards the left upper abdomen, like this. Whereas for the kidney, we don't go from the right iliac fossa. We examine if we examine the right kidney, we'll keep our examination to the right side, and if we examine the left kidney, we'll be the left side.
No, like I'm asking that on the left side, we found a palpable mass in the flank region or the left hypochondrial region. How we will differentiate it that it is a spleen or it is a large kidney?
The mass, the upper limit of the swelling will be palpable, and if spleen is the cause, then we can't appreciate the upper limit, and we can appreciate the lower limit.
Another point.
Another point, the presence of the splenic notch, and
Exactly.
yes, and spleen it enlarges in the oblique fission from the
Towards the
left,
umbilicus.
yes, towards the umbilicus, and
And also the blotment, which is present in the
Yes.
renal mass, but not in the spleen.
it will not in the spleen.
The percussion. Percussion is a special value in the outlining the enlarged masses, progressive hemorrhages following the renal trauma. In these cases, the palpation, depulpation is very painful to the patient when the tenderness and the muscle spasm prevent the palpation. It is basically known as a renal punch, which we will be doing for the examination for the renal pain. Auscultation over the costrovertebral area in the upper abdominal quadrant for the bruit. And the causes for the auscultation found the bruit is the renal artery stenosis, aneurysm, or the renovascular hypertension. We will put over the stair 2 to 3 centimeters superior and the lateral to the umbilicus to listen for the bruit, which is present in the renal artery stenosis. And the bladder, for the palpable bladder, at least 150 ml of the urine should be present in the bladder. Percussion is better than the palpation. Bimanual examination is very valuable to assess the bladder tumor based on under the anesthesia, and in the male it is done in the abdominal rectum, and in the female it done in the abdominal vaginal to assess the mobility of the bladder tumor and its fixation to the surrounding. This is a picture of the bimanual examination for the bladder masses that we will come one finger we will put in the rectum and from the palpate from the press from the suprapubic region to assess the tumor mobility. And now comes to the external genitalia examination.
During bimanual palpation, is there a role of putting finger by a dominant hand?
Sorry.
Dominant hand. If a person has a right-handed or left-handed, is there any difference to put it right-sided and then an abdomen on the left side and vice versa?
No, there is no difference. You can palpate you can put the finger with the dominant hand in the rectum or the vagina and can compress with the non-dominant or the dominant hand suprapubically. With whom you are comfortable, you can do with the bimanual examination. But the thing is that you should pick the findings that whether you palpate comfortably with the right hand or the left hand, and you can pick the findings of the mobility or any abnormality in the rectum or the vagina. The external genitalia, which it started from the peno-suprapubic junction, dorsum of the penile skin, coronal sulcus, prepucial ring, penoscrotal junction, and the scrotum. Starting from the penis, we should see that the patient is circumcised or not circumcised. If it is uncircumcised, then we will look for the phimosis and the paraphimosis. Then if it is uncircumcised, we retract the foreskin and we'll see for the meatus that it's normally placed or the narrow. Hypospadias or the epispadias, ulcers, vesicles, any warts, or any the urethral discharge present on the examination. Then we will go for the scrotum. We will look for any sebaceous cyst, spermatocele, hydrocele, varicocele, torsion, epididymitis, and the testicular torsion. Testicular self-examination should be done for the testicular cancer awareness, and there is a steps that the cup the one testis at the time using the both hands. Examine by the rolling the testis between the thumb and the finger. Femoralize yourself with the spermatic cord and the epididymis. Feel for the lump, change in the size or any irregularities. If you note, then consult with the doctors as soon as possible. Urologist. Now come to the digital rectal examination. Can anyone tell me what is the importance of the DRE in the examination of the urological and the examination of the abdomen? how we will start the DRE, from where, and how we'll approach. Anyone? Dr. Sridhar.
Digital rectal examination is always is mostly an embarrassment for the patient. So we need to make patient comfortable first and explain why we are doing the procedure, and then try to explain the benefit of the digital rectal examination on that patient. Then after the patient has given the consent and he understands the procedure, he or she understands the procedure, we we keep the patient in privacy with adequate exposure and adequate lighting, and the patient and the patient's position, if capable, is a left lateral position with knee towards the leg, which is facing upwards. That knee is towards the abdomen.
Dr. Shriyan, what are the different position in which we can perform the DRE?
We can do DRE in both supine as well as lateral position, especially in lithotomy position. Okay.
So any abdominal examination is incomplete without performing the DRE. It is done to assess the sphincter tone and the prostate size in the urological patient.
What are the important things to look for before doing DRE? Yes. So,
So before we begin our DRE, we have to ask the patient if they have any perianal pain. And on inspection also, we can find out if the patient has any obvious fissure or any obvious hemorrhoids or something that might cause pain to the patient when we start our examination. So that is the first thing that we have to rule out, because if we have an acute fissure, the DRE is going to be very painful for the patient, and it's better to abandon the procedure.
So take the consent from the patient, explain the procedure, inspect the anal orifice, and if there is any fissures present, do not perform the DRE, as it is a very painful condition. And if the bladder is palpable, ask the patient to void before performing the DRE. After introducing a finger, note what is the anal tone, size of the prostate, consistency, mucosa mobility, and the nodularity. And when you remove the finger, then note for any staining, blood staining or the mucus staining, that it is differentiate the carcinoma of the rectum or any anal anomalies. Say thanks to the patient, compile your history and examination, and proceed accordingly for the further workup and the management. Thank you.